Welcome. In this video, we'll be discussing exposure keratopathy, a condition affecting the delicate surface of your eye. We'll explore what it is, what causes it, how it's diagnosed, and the available treatment options to protect your vision. Exposure keratopathy, at its core, is caused by inadequate eyelid closure or insufficient lubrication of the cornea. This leaves the corneal surface, the clear front part of your eye, vulnerable and exposed to the environment. Several factors can contribute to this. One primary cause is nerve damage, particularly to the facial nerve, which controls eyelid movement. This can occur due to Bell's palsy, stroke, trauma, or surgery. Other causes include conditions that prevent complete eyelid closure, such as proptosis, where the eye protrudes forward, and ectropion, where the eyelid turns outward. Decreased tear production, as seen in dry eye syndrome, also plays a significant role, as the tears are crucial for keeping the cornea moist. Finally, certain medications and prolonged exposure to dry or windy environments can exacerbate the problem. To understand exposure keratopathy, it's crucial to grasp the corneal physiology. The cornea relies on a constant tear film for hydration and oxygen supply. When this tear film is compromised, the corneal surface begins to dry out. This desiccation leads to damage to the epithelial cells, the outermost layer of the cornea. As these cells become damaged and slough off, the underlying layers are exposed, making the cornea vulnerable to infection, inflammation, and ulceration. Prolonged exposure can lead to significant corneal scarring and even vision loss. Essentially, the delicate balance of protection and lubrication is disrupted, setting off a cascade of damaging events. While exact epidemiological data specific to exposure keratopathy is limited, it's known to be relatively common, particularly in individuals with conditions that predispose them to inadequate eyelid closure or dry eye. The prevalence increases with age and is higher in individuals with neurological disorders, facial nerve palsies, and autoimmune diseases like Sjogren's syndrome. It's also important to note that patients in intensive care units, often with reduced consciousness and impaired blinking, are at higher risk. The condition affects all genders and ethnicities equally, but the underlying causes may vary depending on these factors. The signs and symptoms of exposure keratopathy can range from mild discomfort to severe pain and visual impairment. Common symptoms include a gritty or sandy feeling in the eye, burning, stinging, redness, excessive tearing, and paradoxically, due to irritation, blurred vision, and sensitivity to light. In more severe cases, patients may experience intense pain, difficulty opening the eye, and the sensation of something being stuck in the eye. It's crucial to pay attention to these symptoms, especially if you have any of the risk factors we discussed earlier, and seek prompt medical attention. Diagnosing exposure keratopathy involves a comprehensive eye examination. Your ophthalmologist will assess your eyelid closure, tear film quality and quantity in the corneal surface. Specific diagnostic tests may include a slit lamp examination, where the doctor uses a specialized microscope to examine the cornea for any signs of damage, such as epithelial defects or ulcers. Tear break-up time (TBT) testing is used to assess the stability of the tear film. Sturmer's test measures tear production. Fluorescein staining can highlight areas of corneal damage. And in some cases, corneal sensitivity testing may be performed to assess nerve function. Exposure keratopathy can be broadly categorized based on severity. Mild cases often involve superficial punctate keratitis SPK, characterized by tiny spots of damage on the corneal surface. Moderate cases may present with larger epithelial defects or early corneal ulceration. Severe cases involve deep corneal ulcers, stromal thinning, and potentially corneal perforation. The classification helps guide treatment strategies. The treatment of exposure keratopathy aims to protect and heal the cornea. In mild cases, frequent use of artificial tears and lubricating ointments, especially at night, is often sufficient. Moderate cases may require more aggressive lubrication, such as gel-based tears, bandage contact lenses to protect the cornea, and punctal plugs to reduce tear drainage. In severe cases, surgical interventions may be necessary. These include tarsorrhaphy, where the eyelids are partially sewn together to reduce corneal exposure, eyelid weights to improve eyelid closure, and in some cases, corneal transplantation. Addressing the underlying cause, such as treating Bell's palsy, is also crucial for long-term management. Preventing exposure keratopathy involves proactive measures, especially for individuals at risk. This includes diligently using artificial tears and lubricating ointments, particularly in dry environments or before sleeping. If you have difficulty closing your eyelids, consider using a sleep mask or taping your eyelids shut at night. Patients in intensive care units should have their eyes regularly lubricated and monitored. Managing underlying conditions, such as dry eye syndrome and Bell's palsy, can also significantly reduce the risk. The prognosis for exposure keratopathy depends on the severity of the condition and the timeliness of treatment. Mild cases typically resolve with conservative management, but more severe cases can lead to corneal scarring, vision loss, and even corneal perforation. Recent research focuses on developing more effective artificial tears and lubricating agents, as well as improved surgical techniques for eyelid reconstruction. There is also ongoing research into nerve regeneration therapies to address underlying nerve damage. Early diagnosis and aggressive management are crucial for preserving vision and preventing complications.